it is obviously a Congress for Africa, and I tried to obviously speak from our perspective, the situation in South Africa in particular, and highlight where we can actually improve things in terms of both maternal and neonatal morbidity and mortality. And I just mentioned a moment ago that we know what needs to be done. We have the Millennium Development Goals, and then to follow that, we had the Sustainable Development Goals, and we know that we need to eradicate poverty and hunger. We need to educate our young people, particularly the ladies. We need to ensure that every pregnancy is a wanted pregnancy. There has to be access to education, to contraception, and so on. But if you look at this column here that shows maternal mortality, admittedly this is an older picture, but I can assure you not much has changed over the years. So that's what we pledged to achieve, and that's what we have achieved. So clearly there's a need to revisit, reset, and have a look at what is happening, where can we improve. If we look at why babies die, and this comes by and large from data from Baragwanath Hospital, and I'm quoting Professor Velapi, who is the head of pediatrics at Chris Hani Baragwanath Hospital, but also some thoughts by Professor Nicolaides in his various presentations, that babies die because there could be genetic defects, could be congenital abnormalities, could be extreme preterm situations, and of course, the issue of hypoxia and CP. But as we see from our own data at Chris Hani Baragwanath Hospital, we may see in the press a baby in Japan survived after 22 weeks gestation and currently is doing well and was discharged home. But realistically, and we had this presentation about 2 weeks ago by Professor Velapi, realistically, if a baby is not at least 28 weeks or at least 800 to 900 grams, has really very poor chance to survive, and not only to survive, but to survive well. And those who survive prematurity, as I show down here, may actually end up having a problem with sepsis, infection, and that is a problem we have in our hospitals because of overcrowding of our facilities. If we look at, this is a paper that was published in the South African Medical Journal, sorry, let's just go back about 2-3 years ago, we see that the situation in the various provinces when it comes to neonatal death and other problems, the majority of them are due to prematurity. As you see, nearly 50% in this pie chart here indicate just that. But as you see, the various provinces around the country, in a period of 5 years, the situation is unchanged. So whatever we are doing is not working, or is not working well to show any results. So I'm going to concentrate on 2 and a little bit main categories. I have left on purpose Aneuploidy out because I know that the guru is going to talk to us later, Professor Nicolaides, and we can't really cover Aneuploidy better than him. So I will speak about the other big conditions that bother us, the ischemic placenta disease, the preeclampsia, if you want, and preterm delivery is the other main one. So we do know that a variety of pregnancy disorders can be associated with placenta ischemia, but once you have entered a vicious circle, eventually you follow a common biological pathway, and that is basically poor placentation in early pregnancy, which can be multifactorial, and we'll elaborate a little bit on that just now. That leads eventually to an insufficient placenta that cannot provide the goods, the oxygen, the nutrients to the baby to thrive. And that failure to provide adequate nutrients and oxygen eventually leads to intrauterine growth restriction, to preeclampsia, to placenta abruption, and that is worldwide obviously a big problem. We also know over the years, we have learned a great deal that maybe we're now dealing with two different entities. We're dealing with an early preeclampsia and a late onset preeclampsia that possibly has a different pathophysiology altogether. And although the late onset preeclampsia is difficult to identify sometimes, and sometimes we miss the diagnosis altogether, thankfully these babies are big enough to do well. The early onset preeclampsia, that is the real headache, is easy to diagnose, but very difficult to manage. If we look at tertiary care hospital like Paraguay Hospital, and we look at the kind of conditions we see in our antenatal clinics, I have highlighted the three conditions that make up about a fourth or a fifth of the patients we see: hypertension, diabetes, and diabetes, make no mistake, is a vasculopathy as far as I'm concerned, and poor obstetric history. And these patients actually make up, as I said, the vast majority of patients we see in a tertiary care hospital. Then why do we end up seeing patients so late in our labor ward? You see the majority of patients that we see in our hospital are coming during labor, intrapartum, which means our hands are tied. There isn't really much we can offer these poor ladies in terms of managing their condition and helping them with their labor and their baby. Clearly, that's a problem. Clearly, something has to be done to reverse that red color to more blue, to be proactive and be prepared to anticipate the problems at hand that are going to appear in these particular pregnancies. So what we need to do is to look at pre-pregnancy, look at the personal risk modifiers, as we call them. In other words, identify the risk factors that these young women present with, and try and sort them out, if possible, before even they embark on a pregnancy, and then continue with a very, very clear kind of plan, prospective plan of action, where we look again at the baby and the mother at 12 weeks, where we identify not only aneuploidies and other abnormalities, structural abnormalities, but also identify risk factors that will lead to placenta ischemia and preeclampsia and preterm delivery. Those who then screen positive obviously will go into a more closer follow-up schedule. We will obviously monitor them closely. We'll see them again at 20 weeks or thereabout. Again, we look for fetal abnormalities and structural abnormalities, but the main emphasis here should actually be the impaired placentation and the risk of preterm delivery. And then a third scan, or at least a third assessment towards the third trimester between 32 and 34 weeks, not to assess this time fetal abnormalities, but to assess fetal growth, fetal well-being, maternal well-being, and start making plans for delivery. As I said earlier, if preeclampsia and ischemic placenta disease was an easy condition, then we wouldn't have this variety of factors that actually influence the disease, and there would be one treatment for that condition. Unfortunately, is neither the case. There's a variety of reasons that may lead to preeclampsia, and there's a variety of treatments, sometimes depending on what is the underlying pathology. So we may have fetal reasons, we may have maternal reasons, systemic, for example, thrombophilias, or chronic disease such as renal diabetes. We may have a placenta disease, or may have external maternal factors such as smoking, infection, and so on. What we need to do is to be aware of these possibilities and try and identify these issues, these problems, these underlying problems well in advance, to try and manage as much as we can before a patient embarks on a new pregnancy. For example, if we have a patient that gives a history of diabetes or obesity, for example, metformin has been shown to reduce the risk of ischemic placenta disease by a lot. And there, highlighted in red, the low-dose aspirin. If we have a patient with thrombophilia, whether it's inherited or acquired, again, this patient may actually do well to be assessed properly and be put on anticoagulation and other immunomodulation medication even before pregnancy. We need to make use of what we have learned so far. We need to be aware of what is available and make use. And I take it in the government sector, not only South Africa, I would imagine in the whole of Africa, the biochemical markers may be a luxury that we do not have yet readily available. But nobody stops us from getting a good measure of the blood pressure, good history, and actually look at the Dopplers, uterine Dopplers to start with, and obviously then fetal Dopplers later as the pregnancy progresses, because these things should be readily available from the moment we have an ultrasound machine available. And by doing so, we're actually more prepared to be proactive instead of reactive in managing whatever condition we identify. Just a few words about those fantastic markers, the biochemical markers that actually I think should really be included as minimum standard in all government hospitals, because it helps identify those patients who are destined to develop preeclampsia, and actually by putting them on some inexpensive low-dose aspirin may actually save their lives and save their babies' lives. We know the fantastic role that the placenta growth factor as a biochemical marker plays in the first trimester, and we also know that now we're talking about the ratio of S-fleet, that soluble fleet, over the placenta growth factor as a good predictor with a fantastic negative predictive value of patients who are destined to develop preeclampsia later in pregnancy. And I say negative predictive value, basically we save money by knowing that the patient will not develop preeclampsia in the next week or 2 or 3, and therefore by not admitting her, we save ourselves and our hospital and our province money. If we look at the part A, that is now pretty standard in terms of the diagnosis of Down syndrome, it's a fantastic predictor for poor outcome in pregnancy and a fantastic predictor for placenta function. So we can actually use part A to screen both for Down syndrome and screen for preeclampsia. A lot is to be said about the antiphospholipid syndrome. It is a condition that actually, let me just go back, that actually is being discussed in so many congresses, and there's no unanimity or agreement on what is right and what is wrong. We disagree, for example, with the biochemists and the physicians and the hematologists that insist in having 2 positive lab results that identify that there is a potential antiphospholipid syndrome. We feel that only by looking at the clinical picture and the history of the patient, we should be able to make a distinction between a patient who is destined to develop just preeclampsia or a patient that may actually have an underlying antiphospholipid syndrome. And this is readily available on the internet. I have listed the 3 conditions here and the clinical criteria. If we have 1 or more unexplained deaths of a morphologically normal fetus at or beyond the 10th week of gestation, if we have 1 or more preterm births of a morphologically normal neonate before the 34-week gestation because of preeclampsia or severe eclampsia, if we have features of recognized placental insufficiency, or if we have 3 or more unexplained consecutive miscarriages before the 10th week of gestation in a morphologically chromosomally normal fetus, that actually should qualify as antiphospholipid syndrome. I accept that is not straightforward. I accept that people may feel that we are overreacting on that. Maybe there is something called seronegative antiphospholipid syndrome. That is an entity that now is gaining momentum. And maybe even if you test negative, you may be having antiphospholipid syndrome. Or even worse, maybe there is a distinction between what we're talking about, the obstetric antiphospholipid syndrome, versus the non-pregnant thrombotic antiphospholipid syndrome that the hematologists are talking about. And these things need to be eventually looked at carefully and separated. What we do know, if a patient, for whatever eventually reason, gets classified as antiphospholipid syndrome positive, she does well with anticoagulation, and particularly with low molecular weight heparin and low dose aspirin. Sometimes this may not be enough, though. Sometimes we may need to give other medication, like statins, for example, that we know that have a beneficial effect on the endothelium, have a fantastic, actually, sometimes outcome in those situations. We may have to consider plasmaquine or other tumor necrosis factors, anti-inflammatories, and so on. What we know is that whether we look at the baby from the biological and biophysical kind of profile, where we know how the baby will react to a hypoxic environment and eventually will lead to hypotonia, absent fetal breathing, absent fetal movement, and an abnormal CTG, and that is basically the Manning's biophysical profile, or whether we are able to look at the vascular redistribution and know, for example, that the baby will prioritize blood flow to the brain, to the adrenals, and neglect, if you wish, blood flow to the kidneys, to the lungs, and so on. That's why we also get the oligohydramnios. Whether we're able to do Doppler studies or look at the biophysical profile, it doesn't matter, because it is the same baby, the same patient we're looking at. But talking about Dopplers, I think let's just put everything on one page. It is important to say that we need to understand the sequence of events, that a baby will not become growth restricted straight away. It will start showing the trend to growth deceleration, and eventually will become growth restriction. By the time this happens, you start looking at the vascular redistribution with an abnormal MCA, middle cerebral artery. In the meantime, the kidneys are underperfused, so you have oligohydramnios, and eventually the baby starts decompensating, and we start looking at abnormal CTGs and abnormal ductus venosus flow. And in that case, that baby needs to be delivered, otherwise the baby dies. Sometimes our hands are tied, though, because the baby is too small to be delivered. And then what do? I said earlier that by identifying those patients who are destined to develop preeclampsia, and by managing them with a very inexpensive low-dose aspirin, we actually save a lot of money and a lot of lives and a lot of hard feelings in our community. So it is important also to mention here that aspirin needs to start early to actually have an effect. We know that if we start aspirin late, if we start aspirin in the second trimester, and a study by Chris Yu many years ago in London at Kypros's unit showed just that, it doesn't actually work. Why doesn't always aspirin work? Well, maybe because we're dealing with unaddressed issues that we haven't identified, and we're managing a patient maybe with something that is not enough. So in terms of plan of action, and I'm going to, for the sake of saving time, go to the third trimester. And if we have a patient that shows early IUGR signs, and we have absent endostolic flow in the umbilical cord, and the baby is more than 34 weeks to deliver, if we have a patient that is showing signs of preeclampsia with abnormal ductus venosus flow, we may actually need to consider delivery much earlier, provided our hospital can cater for such prem babies. So I'm going to move to the second big group of conditions that need to be addressed, and that is the preterm delivery. And in our own hospital at Chris Hani Baragwanath Hospital, we found that we have double the number of patients who present with short cervixes, defined as less than 15 millimeters, than the international literature from Europe and Northern America, that they describe their short cervixes as probably being present in about 2% of the population, we found in our own population 4%. Does it matter? Of course it does. Because if we look at the breakdown of our results, if the cervix is very short, less than 50 millimeters, we see that the majority of patients actually go on to deliver prematurely, and only 50% of patients actually manage to go beyond 37 weeks. So it does matter. If we look at patients who have an intermediate long cervix between 15 and 25 millimeters, we see that they do better, but still not great. And only those who have cervixes that are longer than 25 millimeters, the majority of them, 90%, will go beyond 37 weeks. So here we can see a clear association between a short cervix and preterm delivery. So a study was done, run by Ermos Nicolau in his group, and a lot of our hospitals, Paraguanath was included. We looked at the value of circlage in management of the short cervix, and although there was a trend that showed some benefit, it was not statistically significant and actually never gained momentum to show beyond any doubt that circlage was actually very good. However, looking at the numbers and speaking to statisticians, they say that it would eventually show benefit. The numbers were just simply too short. But then again, we needed 200,000 patients to be managed to show some effect, which was logistically almost impossible. However, that led to looking at other alternatives, and that is the progesterone, which is fairly inexpensive and shows actually very promising results. And as you see in this study by Fonseca, where a very large number of patients actually were randomized to either get placebo or progesterone, there was a nearly 50% difference in the two groups. So it clearly worked. There was a lot of criticism over the years. A lot of studies maybe showed different results, but a recent meta-analysis by Roberto Romero actually showed that progesterone does work beyond any doubt, and that is despite the Optimum study. That was a big study that kind of caused a bit of confusion at some point. So progesterone does work. And not only that, but also in a subsequent meta-analysis in twin pregnancies, Roberto Romero also showed that it works in twins as well. So I think it's safe to say for a drug that does very little side effects actually may be beneficial and should be considered together with the aspirin, inexpensive drugs that are gaining momentum in saving us a lot of problems later in the pregnancy and severe prematurity with cerebral palsy and all the issues that come with it. And my last 2 pages, and I'll finish with my talk, is about diabetes that seems to be neglected in various fora when we talk about screening for stillborn and abnormalities in pregnancy. And we talk about aneuploidy a lot, which is fair enough, but in numbers, I think diabetes should really be way above aneuploidy in terms of our priorities in screening. We know that there are risks to both mother and fetus if we are dealing with undiagnosed diabetes in pregnancy. There is the risk of shoulder dystocia, for example, and birth trauma, the risk of neonatal hypoglycemia, and obviously the long-term risks to this individual's health and the Barker hypothesis of conditions later in life. But we need to adhere to the recommendations, and this is all described, and we estimate in South Africa to have 10 to 12% of our pregnant population may actually fulfill this criteria to be screened for diabetes in pregnancy. That is repeated sugar in the urine, previous history of gestational diabetes, unexplained stillbirth, unexplained perinatal death, congenital abnormalities, big babies, big BMI, more than 30 kilograms per square meter, or, for example, polyhydramnios. So the 75-gram OGTT is what is recommended. And if we adhere to these values here, we can actually make a huge difference in terms of diagnosing and managing, sometimes just by sorting out the patient's diet. And I thank you for your attention. That's my last slide. Thank you.